start now. My name is Gus Cairns. I'm coordinating this webinar. Welcome, everybody. This is our new webinar. The title, as you see, is No Infections Seen, CROI 2015 as a potential turning point for the role of PrEP in combination HIV prevention. It's a question mark. This is definitely the first, our first webinar post CROI, and you may have heard the news from the CROI 2015 conference. I'm sure we'll keep talking about the news presented in that conference for the months to come, and probably those data and sort of policy discussions coming later will have impact in the way we think about combination prevention from now on. So we thought it would be very interesting to have with us today, and we have to appreciate his kindness as usual, to have Gus Cairns to do this presentation for various reasons. Our intention is to help sort of disseminate findings from or presented in a conference like CROI, which in some cases is not so accessible to many people for various reasons. But so Gus is one of the 3 full-time editors at aidsmap, based in the United Kingdom, which is a space where actually scientific information is sort of translated and is able to reach more people. But he's also a member of the European AIDS Treatment Group, where he leads in prevention, and he's the co-chair of the steering committee of the PROUD pre-exposure prophylaxis trial in men who have sex with men in the UK, which was in fact one of the stars of CROI. Gus also likes to talk about himself when he introduces himself as a person, as a survivor of HIV. He was diagnosed in 1985, has lived with HIV for 30 years, and well, now actually he's a qualified psychotherapist, but in his pre-HIV career he was a social worker working with young homeless people in London. Gus was also editor of the UK's first magazine for people with HIV. He did this between 1998 and 2003. So we are having this presentation that I'm sure will be appealing to several audiences. As you know, it's being recorded and it's going to be uploaded to our website and accessible to the internet. And during the presentation to show me the slides, and also if you want to post any questions, you can use the chat window for that purpose. So it's my pleasure to leave the audience with Gus Cairns. Good morning, Gus. Thanks for being here.
Hello? I'm not sure if I've been handed over to because we were getting feedback.
You sound great.
Yeah. Sorry?
You sound great. Go ahead. Thank you.
Right. So I'm starting. Yes. Okay. All right. Well, thanks everybody. Yeah, I mean, I've been introduced pretty fully, so I'm not going to say anything more about myself. I'd like to explain the title. I joked that in my reports for aidsmap from CROI, I was getting tired of typing the phrase "no infections seen" in reports I'd done on quite a few of the studies of PrEP and indeed of treatment as prevention that have been presented there. This doesn't mean to say that no infections were seen in any of the PrEP studies. It means that I kept on saying, well, we still can't find anyone in any of these particular studies. There's been infected while they were actually taking PrEP or antiretroviral therapy. And I think this, these last few results have really sort of underlined what we knew about the potential of these technologies. I want to give you a little bit of background. I've got 60 slides in 45 minutes, so I'm going to have to talk quite fast. Tell me if you can't understand me, though. Okay, so how do I advance my slides? That's this isn't advancing. Okay. Okay. Globally, HIV infections and AIDS-related deaths are going down. I mean, this is a great achievement, and really, I mean, they've been, in terms of sort of the death toll from HIV, this has been going down since the millennium, really. And a lot of this is due to simply an epidemic that is burning itself out in the highest prevalence countries of the world in some places, but is also due to treatment, I think. But as we know, we have a problem with HIV infection in what the WHO has called key affected populations. This is by no means just gay men, but given that the studies I'm going to be talking about were studies in gay men, I want to talk about them specifically and then talk about other populations at the end of the presentation. This is a slide I showed to EATG in January, and this is just infections in Western Europe and Central Europe. And what they show is that infections in gay men, which are the top line in the first three graphs, are going up in all Western and Central European countries, and in case of the previously low prevalence countries of Central Europe, going up exponentially. And we know that this is a global problem too. We know that there is no country in the world now, I think, where HIV prevalence in the rest of the population is anything like HIV prevalence in men who have sex with men. And we know that there are some countries where prevalence and incidence in gay men has been increasing alarmingly recently. One case is the Philippines, for instance. So what can we do about that? I mean, we have a lot more prevention interventions available to us, or at least ones that have proven scientific basis than we did 10, 12 years ago. This is kind of a little slide about the sort of basic scientific data we had on the prevention interventions we had available to us in about 2003. I'm not going to go into this in detail because it could take it's worth a presentation in itself. And this is kind of what we have available up to mid-2014. In other words, this doesn't even include the recent interventions. PrEP is the red bars. And as we will later find out, we can now start slotting two red bars further to the right in this. And the sort of pinky purple magenta colored bars are prevention through HIV treatment, which, as you can see, are still probably the single most effective way of preventing HIV. Let's just show I know what I'm doing. So what can we do? What interventions do we have? One thing I want to say is that we still have condoms. Condoms are still very effective against HIV. The UK epidemiologist Andrew Phillips has calculated that if, in the unlikely event, all of the gay men using condoms in the UK would stop using them tomorrow, HIV prevalence would double within 18 months. So there's still a valuable way of containing HIV, and globally, condom distribution schemes remain one of the most effective and cost-effective ways of bringing down incidence. I stress distribution schemes rather than behaviour change programs. In areas and populations that have had no access before, and this is a really interesting slide by UNAIDS, shown by Karim Abdul Salim at Melbourne last year, showing that condom use has gone up in a lot of countries where access for MSM had previously been poor. So you supply condoms, people will use them. But equally going down in countries where there may be kind of saturation of provision. And I think there is a kind of condom ceiling, as it were. Jim Pickett invented that phrase, I think. This is the longest single data set I know, and it's from my own country, about sexual behaviour in gay men. And in fact, it goes back even before this. This is the UK Gay Men's Sex Survey. Sigma Research, the people who do this, will say very carefully that this is not the same group every year. It's an online survey and it's self-selected. But broad comparisons can be made. And I think what this shows is that no matter what we've tried over the last decade and a half, essentially, we've failed to push up the level of condom use in gay men. And in fact, it may be slowly going down. This chart shows unprotected sex, condom-less sex, rather than condom use. So that the rate of that is slowly going up. Treatment as prevention is probably, according to UNAIDS, the single most important contribution that can be made to bringing down HIV incidence and prevalence rates globally. And we all know that they have issued this very ambitious target, 1990, to try and get as many people virally suppressed as possible. But as we also know, it's very difficult to get a sufficiently high proportion of the HIV population suppressed to start having a real impact on HIV prevalence, especially in kind of what you might call focused epidemics, where HIV tends to be transmitted more rapidly and with higher incidence. And although even the UK, which is the top left, we're one of the best countries in the world when it comes to viral suppression, with 58% of the general population and 68% of gay men suppressed, that still doesn't seem to be enough to bring down the rate of HIV infections in gay men generally. And the reason for this is because, and this slide is a little complex, but it basically shows that only a tiny proportion of HIV infections now are spread from people on ART, and only a relatively small proportion from people who are diagnosed. So, PrEP. PrEP is not a new idea, and it's taking medicines to prevent medical conditions is not a new idea. Dates back to the sort of 19th century when people used to drink quinine in their gin to prevent malaria, and we've used it for other diseases like TB, like PCP in people with AIDS, statins for heart attacks, and of course, although pregnancy is not a disease, the thing that probably bears most resemblance to PrEP is the contraceptive. So, and it's had a long history. The first animal study was done by the people who were developing the drug that later became tenofovir in the mid-90s. And certainly in mother-to-baby transmission prevention studies, babies were given HIV drugs to prevent them getting HIV through breast milk as early as 2002, 2003. PrEP has always been controversial, and as you may know, the first adult studies in Cambodia and later in Cameroon and Nigeria were terminated to some extent due to activism amongst people who thought that there were not sufficient protection for trial participants, and that extended into other trials such as the Bangkok tenofovir study. There is something about PrEP which seems controversial, and my theory about it, although I won't talk at length about this, is because it's actually seen as being potentially very effective, but it is separate from the occasion of sex. And so people feel about it very often in the same way as they feel about harm reduction for people who inject drugs, I think. It's controversial for the same reasons. We did have an indication of effectiveness as far back as 2006, but our first significant result was what was seen in iived, the study you're probably all well aware of, 44% effectiveness amongst the whole participant group. Okay, so taking out the bars, as it were, from my previous study, this is what we now know. This is the data from the reduction in HIV infections amongst the important studies, the large studies we've seen so far, PrEP, and they vary from 0 in voice and then PrEP, to, as we now know, 86% in both IPEGAY and PROUD. And this is obviously a terrific variation in the results seen. And the reason is entirely to do, pretty much entirely to do with the adherence of the trial participants in the studies. And this was a kind of a shock to researchers, not just how low the adherence was in some studies, but how much lower it was than the participants were willing to state to the researchers. It was only about 50% in IPREX, and it was less in the two studies in South Africa that largely dealt with young women. But on the other hand, adherence can be very high. And what we've seen in partners PrEP, which up till IPEGAY and PROUD was the most effective study we've yet seen, was that adherence was very high. And that's because I think that was a study in couples who motivated each other to take the medication. So why has adherence been low? Well, a lot of these studies were, up to PROUD, studies were placebo-controlled. So subjects knew the pills might not work. And in voice and FemPrep, there are accounts of people stockpiling the pills until effectiveness could be proven. Certainly, there are a lot of lifestyle issues that I think researchers didn't realize would have such a strong impact on some of the population studies. A lot of these, the studies in which were less successful were amongst poor young men and women who might not have had much privacy, who might have lived with their families, and there was a lot of fear of being thought to be HIV positive. The stigma militates against adherence, and so does the sort of just people's living situations. There were fears of side effects. That was one of the most common reasons cited, in fact, the most common reason cited for IPREX participants not to go on to the open label study, or that pills would actually raise the risk of HIV. And also it became clear that, especially in low income settings, people were joining the trials for other issues because they got good medical monitoring, pregnancy testing, HIV testing, and also friendship and support. And this may have been a factor not just in studies like voice, but also I think in IPREX. If you look at the lower adherence in the Andean sites, it may be that some of the guys were joining for other reasons, such as to meet other gay men. So up till, well, we still have some of these questions, but as we were waiting for the PROUD and IPEGAY results, these were the kind of questions people had in the background. Behavior change? Would PrEP make people use condoms less to such an extent that it became counterproductive? Would there be big drug resistance? Would there be side effects that affected people's ability to adhere? Would adherence be durable? What would it cost, and what would cost effectiveness be? So, with those in mind, PROUD was developed. And PROUD was developed with a very specific aim. It wasn't developed as an effectiveness study. It was developed primarily as a behavior change study to see if people would indeed change their behavior if they knew they were taking PrEP. This was the first study of its kind which compared two arms where one of the arms knew that they were on PrEP. It was not placebo controlled. What it was a immediate versus delayed study. It was in high-risk gay men, and basically it divided the group it randomized the group into two groups, some of whom got PrEP immediately and some of whom waited for a year before they started taking it. They were also offered 3-monthly STI and HIV testing, monitoring, safer sex support. They kept diaries of their own sexual activity, lots of opportunities to support and network. Okay. And 545 were the number that were enrolled. I'm just going to say that's the figures for the trial because I'm aware that I'm going to go on. I need to talk very quickly. Okay. So this was a sort of fairly highly well-educated group of gay men in the UK, largely white, 60% university educated, mostly in women, nearly all gay. Very high rates of recreational drug use. I haven't done the slide where we split that up, but I think that's just typical in a way of the gay scene, particularly in London and a few other places like Manchester and Brighton, where Proud got most of its participants from. There was a proportion of people in the immediate arm who never started PrEP, and that was taken into account. In terms of adherence, Proud was done as close as possible to real-life conditions, and that meant that there were several things that might have been included in other studies that weren't included in Proud. For instance, people were not screened before they started taking PrEP, and this impacts on some of the results. Basically, people came along to the clinic, they were tested for HIV, and they walked, and if they were in the immediate arm, they walked out with their pills in their hand. Okay, so this does mean that there were a few cases where people turned out to have acute HIV at the time they started PrEP. In terms of adherence, however, what we do know is that 56% took sufficient drug for 100% daily dosing, and overall, the drug prescribed covered 86% of days in follow-up. I think one of the interesting things we've seen in PrEP is that the percentage who are adherent is often very closely related to the percentage, to the effectiveness figure, which I think is more evidence that if you actually do take PrEP, it works. Okay. They did do a subgroup analysis of drug levels in participants who reported high levels of adherence, and the correlation was 100%. In other words, if participants said that they were taking PrEP, they were taking. There was extraordinarily high numbers of Proud participants who took post-exposure prophylaxis when they were in the deferred arm, 31%. Nearly a third took post-exposure prophylaxis during the study. And also, I haven't shown this, but in the at baseline, a lot of the men had taken post-exposure prophylaxis in the year preceding joining Proud. PrEP is widely available in the UK, reasonably easy to access. And I think one of the things that will, I think, encourage the authorities to license the use of PrEP in the UK is that this shows that gay men are already trying to use antiretroviral therapy to prevent themselves getting HIV. This is the sort of, this is the meat of the study. These are the infections that were seen in Proud, basically. And as you will see, there's quite a lot of infections in the people who were in the deferred arm early on in the study. The risk behavior doesn't seem to have decreased during the study. It certainly didn't increase either. But this may just sort of reflect the kind of background level of risk that men who joined the study were running at the time that they joined the study. Okay, I will talk about the 3 seroconversions later. And the bottom line is that this was this equated to 86% efficacy. I call it effectiveness, whatever. So that were 22 infections versus altogether 3 in the immediate arm, 19 in the deferred arm. And there's this very important figure called the number needed to treat at the bottom. Okay, that is the number of people you would need to give PrEP to in order to prevent one HIV infection. And in Proud it is 13. In IPREX it was 52. And that has a huge impact on the cost effectiveness, the potential cost effectiveness of PrEP. Were we to introduce it generally, and were its effectiveness to be as it is in Proud. So, seroconversions in the immediate arm, 2 were lost to follow-up for over a year and turned up at other clinics with HIV infection months later, almost certainly not having used PrEP, or one said he hadn't been using PrEP. 1 did not test positive at day 1, but did a month later. And according to his own account, he was almost certainly infected in the week before he started PrEP. 6 participants were found definitely to have already been infected with HIV at the time they started PrEP. In other words, they took their first PrEP dose away from the clinic, they had an HIV test that same day, and later on it turned out that they were already positive on that day. And of course their PrEP was immediately stopped and they were put on treatment. So 2 who tested positive after joining the immediate arm, 3 whose HIV test turned out to be positive on the day they started PrEP developed drug resistance to tricycline. That's definitely one of the components of Truvada. None to tenofovir, which is the more important one. But that does underline that if you take PrEP and you already are coming down with HIV, then drug resistance is highly likely. Its long-term consequences are probably not grave in terms of your prospects for HIV treatment. FTC resistance is very common amongst people taking antiretroviral therapy, and it doesn't particularly impact on your prospects. And also, I mean, luckily, acute infection in people starting PrEP is a relatively rare event, but it just does underline that if you take PrEP and you're coming down with HIV, you're highly likely to get drug resistance. This is the chart on STIs, and this compares STIs in the immediate and the deferred arms. Now, what you'll see is that there are very slightly higher levels of STIs recorded in people on the immediate arm, but that nowhere is this statistically significant. And this may be because more people in the immediate arm, for understandable reasons, their retention rate was somewhat higher. They tended to come back to the clinics more, and so they actually got more STI tests. So it may purely be that they just had more diagnoses rather than that they actually had more STI. Really, the sexual behavior, yes, there we are. The sexual behavior did not change during the year's worth of the study that we're looking at here. I should say that PROUD is continuing with PrEP on offer to all, and so we will still have more data by the end of the study on whether sexual behavior changes in the longer term. But certainly in the randomized phase of the study, there was hardly any change in sexual behavior at all in terms of number of anal sex partners and how many were positive. It's also worth noting that even in this very high-risk group of gay men, where prevalent incidence turned out to be nearly 9% a year, which is incredibly high, even so, condoms were used in the majority of sexual encounters. Okay, that's the summary of PrEP. And then the extraordinary news came through. I remember this. I was at Cape Town at the HIV Research for Prevention conference back in November, and we'd already heard the very exciting news that PROUD, quite unexpectedly, had to de-randomize early because it showed that we actually had a result on effectiveness when we never expected it. It was only intended to be a pilot trial, and we thought we'd need a much bigger study to prove effectiveness. And then I was actually at the Cape Town meeting, and Emmanuel Trenado, who is head of ED and in a way my equivalent, almost you might say, on the iived study, came to me and said, "We've had a look at our data, and we're having to do the same thing." I was absolutely astonished, astounded, and very pleased. And then, as we heard at CROI, this rather wonderful finding that iived had exactly the same effectiveness as PROUD, 86%. So iived is a very different study, and I think the fact that they produced the same effectiveness is important in itself, because it shows that PrEP is a sort of robust and easily adaptable strategy if you get high enough adherence. So iived was testing a placebo-controlled trial, that's important, testing a intermittent PrEP regimen, an on-demand PrEP regimen, they called it. Okay. Just the study design. And this shows the regimen. People were basically asked to take a double dose. Double dose was based on animal studies. In the day before, they anticipated having sex. That's 2 tablets of Truvada or placebo. Then if they actually did have sex, they were to take 1 tablet up to 24 hours later and another tablet the following day. And people said, oh, that's a bit complicated. People will never remember that. But as we'll see, that didn't seem to impact on it. So this was an even smaller study than PROUD. And in the end, the analysis is 400 men, exactly. Here's their baseline characteristics. I won't go into this except to point out that a high proportion, not quite as high as in PROUD, were also using psychoactive drugs, and their sexual risk profile was relatively similar, but a bit higher. Okay, this is the Kaplan-Meier curve for infections in IPG, and as you can see, very obviously, there were a lot more, 14 in the placebo arm, 2 in the Truvada arm, and as I say, exactly the same relative reduction in incidence as in PROUD, 86%. And the number needed to treat to prevent 1 infection in IPG because it was a small study was 18, but still a lot higher, a lot lower than in IPG. Jean-Michel Molina, who presented at CROI, went into a lot of detail about adherence because obviously this was a complex regimen, and establishing exactly who took the pills and when is an important part of this study, because we want to know whether it was as effective in people who had not much sex and only took it a couple of times a month versus people who had a lot and were on it virtually daily. Median number of pills a month was 16, so about 50%, what you might call 50% adherence in terms of if you were taking it daily, but they weren't asked to take it daily. So they took it about half the time. But a high proportion, well, a fair number were taking it more or less daily, and a fair number were taking it, you know, I think the lower quartile, the lowest 25% were taking it only about 4 times a month. Okay, and 12% received post-exposure prophylaxis. This, I won't even attempt to analyze this, but this wonderful kind of tawny rainbow actually shows the individual adherence profiles. I think it's easier if you turn it around and read it vertically, but it basically shows that there was terrific variance both between individuals and over time within individuals about their adherence, which actually underlines the point of doing the study, is that people vary terrifically their PrEP taking from month to month, very often according to whether they perceive they're at risk, whether they're having sex, whether they've just started a relationship, all those sort of things. And although there were some people who almost never took it, and some people who took it fairly constantly, the most consistent factor was inconsistency. Okay, so about 45% took it exactly to protocol, and about another 30% took it, but perhaps not quite to protocol as they might have done, and slightly more than a quarter basically didn't take it. This is per act. This is not per individual in terms of when they took it. I won't go into adverse events while we're out of time, just to say that there was nothing alarming. And these are the sexual behavior curves in IPG. You wouldn't necessarily expect sexual risk behavior to change in this one, or at least to diverge, because this was a placebo-controlled study, so they didn't know if they were on PrEP. And so the issue in PROUD, where to see if people actually changed if they knew were on PrEP, isn't an issue. And these are the STI figures, fairly similar, but a bit lower to PROUD. Okay. Now I want to go on to talk about a couple of other things before I talk about the implications. There were a number of other good PrEP presentations at CROI, and one of them was this terrific study, which was a continuation study of the Partners PrEP trial, which I've already talked about. But this is not the same. These were not the same people. This was a test of a concept to see if a combination of PrEP and antiretroviral therapy in serodiscordant couples could be used to more or less stop HIV transmission between them. The effectiveness of PrEP in the original Partners PrEP study was the highest we'd seen up to Proudly-Lipicae, 75% in people taking Truvada, but still some infections got through. So this is serodiscordant couples, and what happened is that they gave PrEP to the HIV negative partner while the HIV positive partner was waiting to start full antiretroviral therapy and becoming undetectable. Okay, and this is, I think, a bit of a first for an African study. They only recruited higher risk couples, and the way they determined high risk couples was through a kind of algorithm. They know what characteristics that people who are at high risk have, and they applied this algorithm. So if people had a lot of points for high risk, then they were invited to join the study. And this is what they saw with this combination of PrEP for the negative partner and antiretroviral therapy for the positive partner. They compared it with incidents seen in the original Partners PrEP study in the placebo arm. They would have expected about 40 infections in that population, and they actually saw 96% reduction, similar to the HPTNO type 2 study. And the two HIV seroconverters almost certainly weren't on PrEP. This is when I started to say, I was starting to get tired of saying known HHC. Lastly, I want to talk a tiny bit about whether PrEP will become a widely accepted and used prevention intervention, because these studies are all very well. We've proven that it can work. The question is, will it get widely used? Will it make any kind of difference to public health? Okay. And so this is a presentation by Bob Grant, the principal investigator of IFRX, and it's about San Francisco, which, as it has done in so many other cases, has led the way really in terms of HIV prevention. And San Francisco is a bit of an exception in all sorts of ways. It's a small city with a very high gay population, where most of the HIV positive people in the city are gay men. It's a literate, affluent city, highly educated, a good gay culture. People talk to each other about these issues. So in a way, it's your ideal kind of population. But I think it shows that PrEP maybe has the potential to be more widely accepted. One of the things that people have been saying, one of the frustrations people have been having, is that there does seem to be this slow, very slow uptake in the US, amongst where PrEP is already licensed. And of course, we're still frustratingly waiting for a license in Europe. I think Australia has just applied for one. Excuse me, I'm getting dry. I'm going to have a sip of tea. And also, as we know, widespread skepticism still about it within the communities and outside the communities. Okay. All right. And this is what they've managed to do so far in San Francisco, which is quite impressive already, with very high testing rates, very high treatment rates. They have managed to bring down HIV diagnoses, and HIV prevalence is scarcely going up, which is good news. In a survey at the largest STI clinic in San Francisco in November 2014, they found that 16% of their users by this time were taking PrEP, and 60% said they definitely wanted it, and another 27% said they might want it, but they haven't yet decided. And I think that's an indication of the potential future use of it. These are not all gay men in San Francisco. They're people who are coming for an STI checkup, so they're people at higher risk, but those are the people you want. You don't give PrEP to people who are at low risk. It's not cost effective. And so this is, I think this shows that if we get the setting right and the population right, then PrEP may achieve more wide acceptance and use within the community. Okay. It may even be higher than that. They did a sort of calculation of how many gay men in San Francisco were actually at substantial risk of HIV, mostly because they tended to have unprotected sex, some because of STIs, and also they included the smaller populations that often get excluded of at-risk women and trans women. And they found that of those people, 31% were already taking PrEP. And this is just a bit of mathematical modeling to show the impact PrEP could have when added to treatment as prevention. 62% of the HIV positive population in San Francisco is currently virally suppressed. The brown line is what would happen if 90% were, which is what you and Amy want. And the blue line is what would happen if you added in PrEP to the current viral suppression rate. It could have a public impact. And finally, cost. What we're finding in the UK is that we haven't encountered a lot of hostility amongst the authorities and amongst the UK National Health Service. They're mainly worried about the money. As I say, I think in a way this is one of the most important aspects of IFEGAY and PROUD, is that the number needed to treat is so low that it makes PrEP a much more cost-effective proposition. I've actually just written a report for aidsmap based on a Canadian model, which modeled in IFEGAY but using the number needed to treat from IPREP. It showed even if you use IPREX, it's reasonably cost effective unless HIV treatment becomes very much less expensive in the future. But if you then use the number needed to treat from PROUD or from IFEGAY, it's really quite difficult to devise a scenario in which PrEP is not cost effective and indeed does not in the long term save money, because you actually save more in the cost of future HIV infections than you do by spending it on PrEP now. Okay, that's money you spend now in order to save money later, and instituting PrEP on a widespread level would mean that you'd have to make some outlay now. But one of the problems people used to have with PrEP is that it's very expensive, we can't afford it. Well, it looks like if you take in all costs, then it can be afforded. Okay. I've got some more slides. Where are we? I'm not advancing. Oh, yes. So, PROUD and IFEGAY gave us answered some of the doubts about the practicality and cost effectiveness of PrEP in MSM. In particular, adherence is high when PrEP is made available to motivated and well-supported people at imminent risk of HIV. And I like this quote from Bob Grant. He said, the indication for PrEP is that the person asks for it. In other words, we should stop worrying about devising algorithms for deciding who's at risk and who's not at risk. Because if people, one of our findings from the PrEP studies is that people appreciate that they are at substantial risk of HIV if they do. And that was a bit of an issue in some of the South African studies, that people didn't realize how at risk they were. But if they realize they're at high risk, they will come forward and ask. And the Partners Demo Project suggests ways it could be integrated into HIV programs that should read lower income generalized epidemics. And after a slow start, it may be becoming more acceptable within the gay community, at least in the US, where it is already licensed. A couple more slides, that's it. Okay, so there needs to be progress on licensing PrEP in other countries, and I'm going to a meeting with Gilead to chase them about this on next Tuesday. There needs to be implementation research into other populations, youth generally. Getting young girls, young fellas to take HIV pills is hell, even if they have to take them to save their lives, and trying to get them to take PrEP is going to be a challenge. They may be one of the populations that injectable PrEP may be useful for. as may be vulnerable single women in Africa, and also, and this is important, in African communities in high-income countries. HIV prevalence outside of the big cities in the UK is actually higher in women who are from sub-Saharan Africa than it is in gay men, a fact not often appreciated. There are pockets of migrant communities all over the world in which HIV is very high, and they tend not to get the attention that people back in Africa get. Sometimes female sex workers and sometimes people who inject drugs, but there's been a lot of opposition to PrEP amongst these populations, and that's because they tend to use condoms very well in the case of FSWs, and they use needles very well in the case of people who inject drugs. So they have things that work for them, and they don't want those things threatened. So I think we need to respect what communities want and not impose PrEP on them. Further prevention interventions and decisions on funding and allocation. Okay, and that's it really. Thanks to the researchers in particular for sharing their slides. And questions? I've already got. What happens now? Do people?
Thanks so much. Yeah, there have been some questions in the chat window, and more questions are welcome. So, but you know, so I've made some notes of things that people have already written, and I have some other questions as facilitator. But first of all, it has been a fantastic, quite comprehensive presentation, and I think it's going to be very useful. I mean, hopefully we'll reach several kinds of audiences. So before getting into the more specific questions that have been raised, I would like to ask you first, why, I mean, your impression of why do you think PrEP has generated so much resistance, not necessarily among one group of stakeholders, but across stakeholders, and interestingly, across among many community groups, and in relation to it, one of the things discussed to sort of address potential stigma or difficulties around PrEP uptake that has been suggested is about sort of talking about PrEP as something available to everybody or potentially useful to everybody, as opposed to targeted to more specific groups. And of course, the argument for the general targeting is lower stigma and higher uptake. The arguments for more targeted is are related to cost effectiveness, to real need, and to the way in many countries health systems are organized in programs. So programs oriented to this and that population to cover people with this and that inclusion criteria. No? So just to summarize, I mean, the resistance and also the general versus targeted addressing or targeted offer of PrEP.
Yes, I think in terms of the targeting issue, it really is about cost. I mean, one of the best cost-effectiveness studies of PrEP was from Lima, where they really did show that it made a huge difference. That if you targeted people who were basically at very high risk of HIV, PrEP was cost-effective, and it was extremely non-cost-effective if you gave it to people at low risk of HIV, because you know HIV infection in those people is relatively rare, and you're giving them, you know, £6,000 worth of drugs, $12,000 worth of drugs a year. So no health system would do that, really. So it's not the same as arguing, as for instance, testing everybody, where basically you are sort of saving lives, or giving HIV, or supplying condoms for everybody, where of course, you know, you're giving out something very cheap. This is an expensive resource, and it's only it's really only, you can't justify giving it out to the general population because, you know, there are other people in need of other things. In terms of how you square that circle, how you make people aware of it, I think you asked the question, do you think the outcomes would have been different if the level of education had been less? And I think the answer is yes, quite self-evidently so. We are seeing PrEP primarily being taken amongst aware and literate gay men, which are not necessarily the people of greatest need. For instance, in the US, the people of greatest need are young, poor, black gay men, and uptake amongst them has been lower. But then HIV treatment rates amongst them are lower, and for the same reason. It's partially lack of awareness, it's partially lack of expectation. They don't expect the health system to provide them with anything, and partially just lack of finance. It does require co-pays, for instance, to get PrEP in the USA. And so I think, while I think certainly we should do the studies to see if PrEP is feasible amongst populations at risk, I don't think that's a reason to say, oh, therefore it's unfair to give it to the sort of most aware population. If those people are at very high risk of HIV, then they should get PrEP, I think. Okay.
There was, I mean, you addressed the education level question. There's another from Mark.
Yes, I saw that one.
Yeah.
More convenient dosing regimen. I mean, in terms of what Mark asks, in the IFAGA presentation, they said that their regimen might be a more convenient dosing regimen. Mark comments that he recently heard a fellow activist argue that daily dosing is easier for most people. And certainly there was a study done by Sigma Research back in the UK that said more people would prefer daily, and certainly the crowd participants, who obviously had a vested interest, said that they didn't really want to, if it became known that intermittent PrEP was feasible, would they want to change to it? And most of them said, no, I prefer it daily because it's easier to remember. The more I see about IFAGA, the more impressed I am with it, because I kind of had a sort of I kind of had a hunch that crowd was going to work, but I thought IFAGA wouldn't. I'll admit it. I thought this regimen is too complex. You know, this is very risky, and so to find that it had the same effectiveness was an extraordinary vote of confidence in PrEP, and also an extraordinary vote of confidence in the gay men who used it, because by and large they used it correctly, and they didn't have problems with adhering to this apparently complex regimen. And I think that's important news, because it shows that PrEP is an adaptable strategy. It's got lots of forgiveness built into it. It's not fragile. And that's important news. And so I think to some extent, although there's difficult arguments to be had about guidelines and recommendations, I wouldn't care to be drawing up the CDC in the next lot of CDC guidelines on PrEP, or the French ones for that matter. But I think we now are starting to realize that we have a sort of variety of ways in which people could take it. Any other questions?
Yeah, actually, you showed a very interesting graph from iPrEP about adherence and how diverse it was. And I was wondering if, given that people are using a regime based on actual exposure and judgment of each exposure, when before having sex, when they plan to go and have sex, they may have the 2 pills. But what happens if well, I don't know if that was included in the design. No, if they actually didn't have sex or use the condoms, or didn't have penetration, if they still completed the 2 other pills, or if they that event was considered an non-exposure and then it was dropped. You know about that?
That's a very interesting question, and I don't have the answer to it. I think I don't know the answer to it yet, because that really you need to go into detail in a much more granular way. Like PROUD, their participants get sex diaries and things like that, and really that is the data you would need to analyse to get an answer to that. This slide, which I have is up at the moment, just shows really kind of the number of pills that they took, or they reported taking at each by pill count. This is at each 2 monthly visit, and it did vary terrifically, as I say, and that's important information in itself. But I don't know how many took the 2 and then didn't have sex and took and didn't take the other 2. There was one survey I reported recently for aidsmap where gay men were asked to rate the likelihood of their having sex over the next week or something like that. And they found that gay men were a lot more reliable in terms of estimating when they weren't going to have sex than when they were. So I think probably quite a few of them took the double dose and then didn't get lucky, so didn't bother.
Yeah.
You know, whereas I think you know, if you know you're going to be visiting your mum for the weekend, then you probably know you're not going to have sex. Whereas, you know, if you're hoping to get lucky on a Saturday night, of course the chances are you might not be. So there you go.
Yeah, but in the same way as people, I mean, end up making decisions about using a condom right away when given or based on who they are having sex with, whom. I mean, if they know the person, yeah, so they may decide that,
Yeah,
no,
you mean in terms of their estimate of whether they've been at risk or not? Yes.
Exactly.
Well, Jean-Michel Molina made this point at CROI. He said this was in talking about the 30% or so of sexual acts that were not. Here we are. These are individual sex acts, right? So 40, 45%, 43% were actually covered by full PrEP use. In other words, 43% of sex acts. This partially answers your question, by the way. 43% of sex acts were, according to the participants, covered by the full PrEP regimen. 29% suboptimal use. In other words, they took the 2 beforehand and didn't take the 2 after, or they took the 2 after and didn't take the 2 before, or whatever. And 28% of sex acts were not accompanied by PrEP. But as Jean-Michel Molina said, that could be because they were not at risk. You know, they could have been used. These were this is sexual intercourse. It doesn't say whether they were using condoms or not. They may have used condoms, or they may have been with a partner they were absolutely certain was negative. So there you go.
Exactly. That makes it very interesting and probably raises the importance of qualitative studies to complement these findings. And
both of these studies are going to produce a lot more qualitative studies, and of course both are ongoing, and there will be further data from the unrandomized continuation.
Okay, well. Oh, well, I guess we are, I mean, it's already, I mean, the hour is complete, so I think this has been an excellent, very interesting discussion, and it's going to be uploaded very soon to be available for people, for others. Really, thank you very much.
Yeah, will you send an email around?
Thank you. Yeah, thank you very much for this presentation, Gus, and I'm sure we'll keep discussing about this for months to come. Yeah. So, and there are many things we still don't know and have to find out about. So, thanks again, and thanks to all for being here today. Bye.
Bye.
Bye.